Hello, everyone. Welcome to Learning Session 2 of the CKD Management Learning Collaborative. We will give everyone a few more seconds to get settled in. We were talking weather earlier, but hope everyone here is doing well. I cannot believe it's March already. When did that happen? Is it me or is the year zooming on by for everybody? But it's Thursday and we're closer to the weekend. So I hope everyone has great plans ahead, but also we'll be making time just to rest and slow down as well. So if you can, if you're able to, we'd like everyone to just be engaged and continue to learn from one another. And the best way to do that is to have our cameras on. But of course, we understand it's also lunchtime. And if you can go ahead and eat, we totally understand. But if you can turn it on at some point, just so we get to, again, it's part of that all teach, all learn collaborative portion of our session, just to just engage, and we'd really appreciate that. I'm going to give one more minute for everyone to join us, unless, let me see, I think we're good enough on time, or should I go ahead, Jenny? Oop, I think you're on mute.
I was just going to ask Cody and Alyssa if you guys knew which team members were coming, and which weren't, so we weren't waiting, but I see Dr. McGrath joining, and I know there are several other providers, and it can be hard to get away.
Yeah, we have our providers blocked out. I think one of them, Nikki Walls, messaged me and said she'd be just a few minutes late too.
Okay.
Hi, Michelle.
Oh, and there's Michelle. Great.
Yeah. All right. Just for the sake of time, I think I'm just going to go ahead.
Do you want to sit on the other side?
Getting settled.
Close it? Yeah, it's probably best.
All right, so I think I'm just going to get started so we can go through everything we have planned for this session. Thank you again, everyone, for joining today's collaborative. If we can go to the next slide, Jenny, that would be good. Oh, thank you. So again, welcome to Learning Session 2. We're so happy you're here. Before I move on, just to note that Calderon Medical Group will not be joining us today. They're in the process of moving their clinic to another location, but we'll catch them up and they'll be joining us for Learning Session 3. So a quick recap of who Comagine Health is and what we do as an organization. So we were previously two organizations, Qualis Health and Health Insight. And the two organizations merged in 2018 and rebranded as Comagine Health. We were previously two organizations, Qualis Health and Health Insight, and the two organizations merged in 2018 and rebranded as Comagine Health. And we're a national nonprofit healthcare organization firm, and we work with a variety of the healthcare system, including community organizations, associations, laboratories, even health departments and districts, with the goal of improving our healthcare systems, improving healthcare outcomes, for our patients. And these are the team that is bringing you the learning session, our wonderful team, Bert being our newest member. And we love having her, but just keep an eye out from emails from her in the future. If we can go to the next slide. And so this is today's agenda. We're going to do storyboards again so that you can continue to learn from one another and your journey this far, and help build those relationships that we're hoping will continue beyond this collaborative. So as you hear the other clinic stories, think about the questions you want to ask and helpful suggestions that will benefit them as well. We'll always want to focus on the all teach, all learn aspect of the collaborative, and we want you to learn from one another. So we're thankful that Dr. Evan Solino is back with us again, and he'll be discussing how to manage CKD in a primary care setting. And we'll also give you time together in your clinic groups to continue your process improvement planning. Then we'll come back together and have you share what your next steps are. And we'd also like your feedback on what was the most useful part of the collaborative today and what we can do differently in other sessions to make it the most useful for you. So keep those in mind as we go through the session. As a quality improvement organization, we're always looking to improve as well, and we would love to know how we can best support you. So your thoughts and suggestions would be immensely appreciated. Then we'll look ahead to what will be coming in between the session and the next collaborative session, and what's planned for learning session 3. Next slide, please. Thank you. So a couple of quick housekeeping items to remember. You can use chat for thoughts, suggestions, questions, but we'd really like it if you come off of mute and really engage with us and the other clinic throughout the session. This is not meant for us to be talking at you. We want interaction. And this is meant to be informal. So you can also share reactions on Zoom, which are always fun. And we'll be recording this main session, but we will not be recording the breakout session. But the recording and the resources we share will be emailed to you as soon as it becomes available. Next slide, please. Also, keep your cameras on as much as possible, and we would like it if you add your clinic's name next to your name. And the way to do that is on the next slide. Jenny, if you can just move that. So just quickly, you'll click on participants, find your name, do rename, rename, and then add your clinic's name onto that slide. And then next slide, please. And a review again of our collaborative norms in order to create a connected environment where everyone teaches and everyone learns. So first, again, we want to commit to confidentiality so everyone is comfortable and feels safe sharing. And also no one person holds all the knowledge or experience to do this work well. We commit to sharing our knowledge and skills, and we are willing to learn from others. And we have frank, respectful conversations. And it's okay to ask questions and give feedback to drive deeper thinking. And we also commit to doing this with kindness. And what is often called failure in other areas is an expected part of our quality improvement process. There's no shame in it. In reality, failure is an important part of quality improvement, and we must embrace it so we can inform changes to our processes. And as we collect, analyze, and share data during this collaborative, the goal is that it informs our next steps to drive improvement. It's not for comparison or competition because each clinic and their circumstances are different. And finally, next slide, please. Just a reminder of the measures we want to improve as part of the collaborative. So we want to increase the number of patients with diabetes who are screened for CKD with an eGFR and UACR. We want to increase the number of patients who have their eGFR and UACR evaluated for CKD diagnosis. And finally, the reason we're doing this is to decrease the number of patients who progress to ESRD and or have a cardiac event related to CKD through management and CKD in the primary care setting. So, and now I'm going to hand it over to Jenny for our next item on the agenda.
Thanks, Lily. So we're going to move into a time of Kitsap and St. Mary's Clearwater getting to talk to us about what you're doing. Again, we want this to be really informal. This is the collaborative piece where everyone gets to share and learn together. So we're going to have Kitsap go first. And Michelle, Dr. Bauer, feel free to come off mute and you can let me know when to advance your slides.
Okay, can you hear me okay?
Yeah.
Good afternoon. Myself, Michelle. I am the nurse and administrator, and this is Dina, our medical assistant that's helping out with us on this collaborative, and I don't believe Dr. Bauer is here yet.
He
Oh,
is.
there
I
he is.
see him logged on. Yeah.
Yeah, he's on mute
I'm
right now, but he
here.
is here.
Okay. Hi, Dr. Bauer.
So a little recap of who we are: Kitsap Medical Group, Internal Medicine and Geriatric Care, just a small private practice established in 1986 by Dr. Sharman with the mission to bring care to the underserved. And so we follow our patients down the continuum, so from the office setting to the hospital to maybe rehab, assisted living, adult family homes, and then on to end of life. And we have been doing this, well, since 1986, but part of the underserved area that we do, along with the facilities, is Kingston, which was established in 1992. And then, of course, we follow our patients in the hospital as well. You can move that forward. We did our introductions already. Largely elderly population, kidney disease is pretty prevalent for a number of different reasons. We do screen our patients routinely with GFR and UACR at least yearly. And that actually, I think Dr. Sharman does twice a year as a routine. And then obviously we want to improve on early treatment, what we can do to try to prevent further progression, and then of course have to see a nephrologist and maybe dialysis from there. So move forward. Yeah, current focus is building reports. It's been a bit of a challenge, so this could probably cover a couple different number of these slides. We were finally able to get the MIPS 488 report implemented with our EHR vendor. It was kind of a wonky little thing, but apparently it's a sign-up type of deal. You don't have access to all the measures unless you actually sign up for them. So we're not able to get the 2023 data, but we were able to start with 2024 and moving forward. And actually, I think we were able to find that Dr. Bauer actually has already diagnosed almost basically 20% of our patients with CKD already. So that was interesting to find. We are also focusing on hiring and training new staff members and moving clinic responsibilities around. So that kind of creates its own bag of concerns, but also positives down the road for sure. You can move forward. Yeah, I just reviewed that with the 20.6. That's what we've got so far this year, and of course we'll keep trying to improve on that.
I have a quick question, Michelle. Is it the number of patients with diabetes that have been diagnosed with CKD? Or your total
diagnosed with CKD right now?
Okay, gotcha.
Yes. Some of the challenges, yeah, probably the same as everybody else: pulling data, prioritizing time, trying to get a good focus in those first two challenges. Again, we've had a lot of shifts in our clinic the last month or two, trying to hire in new staff, try to start getting them trained, that kind of thing. So I think this will calm down a little bit, especially now that we know how to get the reports. Adding the kidney profile test in the workflow into the EHR. I do believe, if I recall right, I did have a conversation, and forgive me for not remembering off the top of my head, but I did reach out to our lab rep, Rich, and we do have that capability. So we just need to pull it into the EHR. I'm sorry, am I breaking up at all?
No, you're good. I can hear you okay.
Okay, great. They just gave me a little message that said our internet was unstable. And then, of course, busy clinic finding administrative time to support the reporting needs, that kind of thing. Dina made a really good observation this morning as well as far as patient challenges go, because it is kind of new, really trying to focus on pulling UACRs along with eGFRs. Patients, there's a little pushback from the patients because they're not expecting it, and so they don't want to give that urine sample at the time, and we are noticing that. I hadn't really noticed it before, but now that it's actually a focus, it's prevalent. You can move forward. So, yep, lessons learned so far. Yeah, persistence, be clear, make sure you get them to prioritize the request because it does take a little while to get anything done quickly. We move forward. So when we're doing any type of orders for patients that have diabetes and hypertension, Dina has had the most focus on adding the UACR. My hope is to present after this, actually, in one of our, we're trying to pull together huddles this year as our new how to help our office staff improve or communicate together. We're going to be introducing the algorithm on if a patient has hypertension and or diabetes. You're going to do a UACR at the same time you do a BMP and focus on that. So we already have it set, and we actually already have an algorithm to that effect, but it was really focused on Dr. Sharman. We're pulling Dr. Bauer in, which changes the workflow for the staff because they're two different providers, as you can imagine. So what you do for one is not always done for what the other one wants. So we are going to be working on that. Dr. Bauer has already updated his dot phrase, so when he does his routine lab orders for a patient on a chronic care management, that's an automatic add to his labs. Training opportunities with newly hired staff and shifts in care teams, that's affected our progress for sure, just by hiring in altogether and the time it takes. But I think that's also starting to calm down a little bit as well. So this will be actually a good opportunity to add this in. I don't right now. That's actually one of my questions for the rest of the group is how do you do that? So it sounds like today's focus at this meeting is along those lines. So I can answer that question better maybe.
Yeah, thanks so much, Michelle. We'll just open it up now for questions, discussion. Yeah, I'll wait.
You mentioned a dot phrase. Is that for patient information, or is that just part of the charting that Dr. Bauer's using?
It's part of the documentation in our EMR system. It allows you to create a dot phrase. So all you have to do is type, dot 2, 3, 4 or whatever, and it gives you a whole.
Oh yeah, I that part I understood. It was what was the content, and like just trying to see if
when I order labs for the next visit, it's in the dot phrase to get a UACR.
Got it.
Thank you all.
Yeah, and Michelle, we're going to be presenting an algorithm today from the National Kidney Foundation, but I'm curious to know what algorithm you guys are using, what treatment algorithm you guys have started using.
It's just created by the provider. So basically, Dr. Sharman created his own algorithm that says if a patient has diabetes, it didn't include hypertension. That hasn't been a main focus. But if a patient has diabetes, do a UACR twice a year. And
Gotcha.
that just gave us so it's a loose term algorithm, I suppose, but it gave us the go-to if we see a patient and we're drawing routine labs and we know they have diabetes, we just automatically do a UACR without having to ask.
Perfect. So like a standing order for that.
Pretty much.
Awesome.
And with me, I do it with hypertension, diabetes, and CKD. So those are the ones I look for.
Great. Anything else before we move on to St. Mary's Clearwater?
Okay. How do you remute the phone?
It's *6.
It is *6. Good. Thank you.
Yeah. Okay, I'll turn it over to the St. Mary's Clearwater team.
Hi, Jenny and everybody else. My name is Cody, Director of Population Health at St. Mary's Clearwater. We have Alyssa Adams, Director of Quality for both on the call. Dr. McGrath is here. And I believe Colleen Bennett is our lab manager at St. Mary's. And she's done a lot of work on this project and has been instrumental in helping us get this rolled out. So just anybody has anything they want to add as Alyssa and I go through this, just stop me and chime in. But this is our service area. We're in north central Idaho, 3 counties, Idaho, Lewis, and Clearwater County. It's about 28,000 people in the size, an area the size of Massachusetts. Really rural, really frontier. We like to brag that there's only one stoplight in this whole area. We're a 2-hospital system with 8 clinics, and like most rural areas, our populations are older, lower income, lower education, and a high burden of chronic illnesses. So, next slide. There we go. So one of the reasons we wanted to join in on this project is because this was really something we tested for, and then after talking with Jenny and Dr. McGrath and several of us kind of regrouped, there was several things we wanted to work on. We didn't have the testing bundle for chronic kidney disease. The evidence-based pathway didn't exist, having a specific registry for this population, no standard order bundles, and then a lack of global care team awareness of clinical interventions to use at each stage of CKD. Those are kind of our main reasons for wanting to join the project. So that kind of guided our solution building going forward. So this is our first PDSA as far as the initial stages, and that's just getting that information out there that we learned in the initial beginning of this project, providing that information to our provider groups, to our labs, to our diabetes educators, getting that information out there, the importance of this kidney profile, and having that guidance built in that allows providers or gives providers, some guidance on where to go when they do find these diagnoses. So what questions do we have? What do we predict will happen? Plan for test to change. You can kind of read through those and see what we did. It's kind of a fun project because Alyssa and I were laughing because it's something we rolled out really quickly, but it was just a real easy lift. If you want to go to the next slide, we were able to accomplish a lot fairly quickly. We collaborated with the provider teams to understand the current state in testing and the need for some new workflows, and that prompted some really good conversations at our medical staff meetings on both sides. We're able to design a kidney profile test that ensures that the best practices that we learned were offered in those in that design. So I could read through each one of these solutions, but go ahead and feel free to follow along or read ahead. But build the kidney profile test in our EMR to include that EGFR and the UACR. Educate all of our staff, that's our diabetes educators, along with our providers and nursing staff. And our laboratory, like Colleen on the call, our laboratory professionals. Implement screening at all sites. So we met with the providers. Dr. McGrath, I don't know if you want to talk about that implementation at all when you presented that information.
Oh, not so much. Just like anything, when you get in front of providers and they think somehow you're telling them that maybe the care they've been giving isn't optimal. It's not always like a love fest, but we got past it.
We're lucky. We have a really good engaged medical staff that really jumped on the information quickly and asked a lot of hard questions and really pushed us to make sure that we had all our T's crossed and I's dotted. So it's been a good learning process. And then adding that kidney profile test to our quality dashboard. Alyssa's the quality guru for our organization, so she's incorporated that and embedded a lot of that work. So we report it out to our boards and all of our clinical teams monthly. So I have lines through those as mostly checked off, and we're currently monitoring those results that we are receiving. We'll show some results here in a little bit. But we revisit those processes on a regular basis, keep looking at the data, and I think we're gonna keep watching our PDSA and maybe develop a new one here shortly. We want to ensure sustainability. Be nice if we could develop a live registry of our diabetes patients and see which ones are diagnosed with chronic kidney disease, which ones were testing and which ones are, or how many, what percentage are being diagnosed. So to have that live registry, the group before us, Kitsap, mentioned pulling data. We'll talk about our struggles with that in a minute. We also would like to bolster our internal and external interventions and resources. And that includes our transitions to our specialists. We do have telenephrology. Dr. McGrath would probably say it's underutilized or not taken fully advantage of. So that's something we would like to work on, as well as with our nutrition interventions as well. I'll turn it over to Alyssa and Colleen. Feel free to chime in here at any time too.
Sorry, this is kind of blurry, but this is just an example of how we've incorporated our kidney profile. And then we list out that it does contain that UACR, the EGFR, and the creatinine for our providers. And then we have a diabetic panel as well that previously included an A1C, a lipid, and a micro urine albumin. And so we replaced that micro urine albumin with the kidney profile to make sure we're ordering it correctly that way. And if you go to the next slide, I think there's an example. So this is the bundle test, an example of what the report looks like when our providers order a CMP and that kidney profile. And Colleen did a fantastic job of getting this in our system. We have very outdated Meditech version that we're using on. So we can't get too creative with it, but it gives you the kidney stage disease calculated. And then it also gives you the recommendations for each of those stages. So that's been nice for our providers. And then the ability to go back and then make sure that we're matching their diagnosis with the correct stage of kidney disease and updating their problem list. Capture that. Probably go to the next slide. So here's our numbers through February. And this is that MIPS 488 measure of looking at the number of patients who received a kidney profile screening with the EGFR and the UACR. And then our denominator is the patients that are 18 to 75 with diabetes seen in the measurement period. So our denominator grows obviously through the year as we continue to see more diabetic patients. I think we've seen about a third of our diabetes patients thus far through February. So we really try to front load seeing those patients in the first quarter of the year. We try to push for that to get early A1C testing. And so that's why we wanted to really hit the ground running with this project early in the year to get that kidney profile test developed and rolled out and available for our providers to start using it. And we're already seeing the benefits of that. Getting more consistent diagnosis of patients with CKD as well. You can see that line's trending up. This is just a look at our patients with diabetes that also have CKD. I think there might be one more slide. Yes, lessons learned. So anytime you have a quality improvement project, there's always good lessons that we learn, and especially with as fast as we rolled this one out, we have some takeaways, which we knew would probably happen, but it was a fairly fast implementation, easy in some ways. As far as provider engagement, we'd like Cody already hit on, we have some really great engaged providers at both locations that just really jumped on this and took it away. Even before we had the kidney profile test developed, they were using our workarounds and solutions to get that ordered before we had that implemented. And just hitting on, there's no such thing as too much education, just continuing to talk about it at all of the monthly meetings and huddles and with lab staff and making sure that everybody's on the same page. And the one thing that we did early on is, like Cody said, embed our outcome measures and made it a part of our quality dashboard for 2024 to track that MIPS 488 and report it to our board as well. Barriers, a couple barriers that we have encountered so far. Colleen had a great process of, she's educated her lab staff to collect the urine first and then the blood second. And so if the patient's not able to leave a urine sample that day, that we're not collecting that blood, that we can reschedule them and have them come back and then do it at the same time to ensure that that test is being done as a whole. So that's helped, that's been great. And then data. We knew coming into this project that data would be a barrier for us, but we really didn't want it to let us slow us down. Like I said, with our outdated medical records and system, most of the data that we're getting is manual data pulls. We do have the ability from a third-party vendor that we use to pull the diabetes core control metrics. So we at least have our denominator of patients, and then we can go through and I pull a registry of patients that have had a UACR and then a CMP, and then we cross-reference those reports to make sure we're meeting all of those criteria. And we do the same to figure out if they have a diagnosis of CKD already. So lots of cross-referencing with reports. We are also in the process of looking to see if we can have the MIPS 48 report built for us in that same third-party vendor. That way we have access to it and it will be less of a lift for the rest of the year. So. And then kind of the last thing, this is one question that we're looking at as we're getting into the testing and emerging questions that we can see in the future is how do we ensure that now we're using these diagnoses to their full coding potential and capturing those HCC codes and fully capturing that disease burden for the patient. And I said HCC coding and risk capture. I think that's all we have. If there's more questions.
Thanks, Alyssa. Thanks, Cody. Yeah, I see Michelle raised her hand.
Yeah, thank you. I like the idea of I don't know if you saw my face go, oh, for doing the urine first and then the labs, but how do you handle the patients with that? Because ultimately then you're asking them to come back again. Are they agreeable?
Sometimes. Sometimes not, but we've also talked with our nursing staff to really, at the beginning of the visit, knowing that, because a lot of our nursing staff will queue up the orders to be put in, and if they can doc the patient and let them know that they maybe having to leave a urine sample, and, you know, if their appointment takes an hour, giving them water and kind of preparing from the start. So, like I said, we've really only had this live since February, so those are some of the kinks that we're still working through. And that was Colleen's idea, actually, with her lab staff. So that was kind of recent.
Okay, I do like that. We have a workflow of we have the patient in because we draw our own labs here in the office. We have the patients in 1 to 2 weeks prior to the follow-up so that the results are available to the provider at the follow-up visit to review. So that's, I don't know if that workflow would work for us because our patients probably wouldn't come back, but thank you.
Colleen, do you have any?
Oh,
Yeah, I was going to see if Colleen had anything input on that or from personal experience.
You know, I haven't heard any negative and any positive. So honestly, I haven't checked up on it much, but I do know that from the communication side, when we do schedule labs, and I do know that they've really been pushing communication also from the lab end and again from the nursing end that there will be, you know, that urine component with that. So I haven't heard of a lot of issues with it, and I typically do hear if people are unsatisfied. So
that's good to know. I will just add that in our work, doing this work with some other clinics, this has come up with each clinic, this piece of, oh, now we have to get more urine samples, and patients aren't used to that and they're not ready to do it. So I'll just share quickly some ideas. Several of the clinics designed PDSAs around this very thing, like what works to get a urine sample from a patient at a visit. And some things they implemented was adding it to their automated appointment reminders that you will get labs done, including a urine sample, so that people are like, okay, I have to use one, or I have to give one when I go. They also educated front desk staff about it. Oftentimes, front desk staff are kind of that first gatekeeper. And so if a patient comes in and asks, oh, where's the bathroom, they can say like, oh, I think that your provider may want a urine sample. Let me check with the nursing staff real quick. Something like that. They just being aware that the patients need to give a urine sample. A lot of patients would go to the bathroom right when they would get there and then couldn't give one during the visit. Another clinic started offering a bottle of water when a patient was roomed. If a patient said, oh, I just went to the bathroom, or I'm not ready to go to the bathroom. And like Alyssa mentioned, that appointment from start to finish is usually around an hour. And so that would give them time to start drinking water. Another clinic that has a large geriatric population found that their urine collection cups were too small, and the patients really hated leaving a urine sample in smaller cups. So they actually they got much larger cups, and that increased patient satisfaction. So those are some different ideas. I think the biggest one that changed it was telling the patients early and often and offering them water at the beginning of the appointment. And that included educating the front desk staff as well. So it's a real thing. Getting the urine sample is a thing. For sure.
Well, and I can say just from our manual, because it's a manual data pool, I can see when they've been ordered and haven't been completed, and we don't have a high volume of these tests not being completed. So I don't know if it's because we were already collecting, microalbumins on our diabetic patients that maybe they're used to the idea of having to leave a urine sample, but we really don't have a lot of orders out there that are hanging open.
That's great. You can actually see that. That's super helpful to see data on something that we have a feeling about, but then to be able to check it is great. Colleen, do you have, or could you share with us things from the lab side that you found interesting or surprised you about this process of implementing this test? Any key takeaways you have from the lab side?
I think just with any new process, it was kind of a grumble and a learning curve. And it is difficult because of Meditech being so finicky. So right now, one issue we're attempting to fix is the fact that when you order a panel, this panel with the chemistry panel, Meditech is smart enough to realize that we don't need 2 creatinines, but it is not smart enough to realize that we don't need to charge for 2 creatinines. So it's kind of and that was something that the lab thought, because we had kind of thought about that, and we looked at it and we're like, well, it's only resulting 1, so it must only be charging for 1. And until billing came back and said, oh no, it charges for 2. So right now we're in a manual process of every time we order either the BNP and the CNP and the CKD profile panel, that we need to go back and credit one of those creatinines. So it's a pain for the lab, it's a pain for billing, but it is an unfortunate side effect of the fickleness of Meditech. And I think, I don't know, maybe I'm just overly optimistic. I think so far it's been fairly good. I mean, it's not terribly pretty, but it's functional. And personally, I just think it's a great opportunity for providers and for patients.
Yeah, thank you so much for sharing. And I'm super impressed with the report that you put together on your own. Especially knowing that you do have that outdated Meditech system. That was very impressive. I was looking at that earlier and was very impressed. So good work. Yeah, anything else for the St. Mary's Clearwater team? I feel like you guys have queued up, both Kitsap and St. Mary's Clearwater have queued up Dr. Celino really well for what we're going to be going over today. He's like, just the things, talking about the treatment algorithms for CKD, some evidence-based algorithms. Also this correct diagnoses and HCC codes. We're going to talk a little bit more about that, always with the caveat that we are not a billing and coding specialized organization. So this is always to the best of our knowledge. We encourage you to run it through your internal billers and coders. I will say Dr. Celino has a lot of experience in this area though. So yeah, if there's not any more discussion, we can turn it over to Dr. Celino. I just want to pause in case anyone else had something they wanted to chat through. Okay, thank you guys so much for putting that together and talking it through with us. It's so helpful to see where you're at and where you're headed. And we're going to move over now to Dr. Celino. I know we heard from him last time. Just briefly, he's the clinical director here at Comagine Health. He also is a practicing family physician at a residency program in Oregon. works with OCHIN and has a long history of working kind of on a larger systems level to improve healthcare. So we are so glad to have you again, Dr. Salino. Thanks for being here with us. I'll turn it over to you.
Yeah, thanks a lot. And thanks to everyone who's been sharing. You all have been talking really through really just some fabulous operational things to get, this issue diagnosed. And we're going to talk through, sort of shift a little bit into some of that, like barriers for clinicians to diagnosing this, and then like what do you do about it when we diagnose it. As Jenny said, we'll just flash this up there. We can move on to the next slide. As we're talking about this, again, we really want to focus. We're going to talk about things like ICD-10 codes and HCC codes in the context of making appropriate and specific clinical diagnoses for folks, and again, managing that appropriately. So we have been, again, talking about the various sort of, in many cases, operational issues that go into how do we actually diagnose this appropriately in the first place, get the urine and the blood and that sort of thing. And again, those are really critical. And I have found in talking with my clinician colleagues about this issue in general, that there's also sort of a perception barrier and maybe an education barrier around CKD generally, especially diagnosing it early. So one of those, again, like we just talked through, is the fact that in order to really diagnose and evaluate it for it, you have to get the blood in the urine. If somebody had diabetes, maybe we're doing that already, but with what frequency? We might have different ideas about the frequency. How do we know what's evidence-based? And that uncertainty can lead to, I'm not really sure, I'm just going to follow what I'm doing. A lot of folks will also say, I'm already managing their diabetes and hypertension. Why do I care if I diagnose CKD stage 2 or whatever? Am I doing anything different? CKD 3A, maybe, okay, so maybe I'm paying attention. Why don't I just wait like I'm doing right now and wait till it gets further along, and then I'll put it on there and manage it. As well as really not being sure like what to do differently, like how frequently, based on what am I monitoring their blood and urine? Do I know, or again, am I gestalting that, or I do it based on what I learned in residency? How do I know this? And then do I really do things differently besides certain things, like I try and get their A1C down and manage their blood pressure best I can? So sort of knowing what to do are real barriers. But I did want to, and I wanted to sort of highlight what Dr. McGrath mentioned, which is when you go to folks and you say, hey, there's another thing that you should be paying attention to that doesn't seem like you've been paying attention to, people get their hackles up a little bit. And these are some of the things that have come up in my discussions. I'm curious from you all, from your clinicians specifically, what are the barriers to them diagnosing CKD, especially early CKD, the early stages of it?
Well, I would just expand on what I was saying earlier. I think just that there was just this perception that we had this pathway that was good enough, and we're following it. So it was an awareness issue. And then you already spoke to the point about, well, so I make the diagnosis, what does that matter? And how is that going to, what's the care pathway? So that's really, I think, some of the reasons that I've heard.
Yeah. Other things that aren't those?
So again, I'm not trying to monopolize. I'm just, well, I was thinking about it. One of the things was actually just dropping the codes for it. So it's not, I mean, diagnosing, like people are like, well, yeah, I knew they were CKD2, but when you look in the chart, you don't see that. And so just add it, everybody, all the providers are super task loaded. We know that. And then if there was something that was perceived to be low value work, are you going to commit an extra 4 seconds to dropping a code that you don't think is going to matter? It's not going to impact even HCC if you're engaged on that. So I think that was a little bit of a barrier, and just it's not a huge task, but those of us that do the work know that it's not a huge task, but it's just one more. And so
Right.
It gets dropped off.
Yeah, absolutely. So again, maybe the test's being ordered, maybe somebody's evaluating the results, but actually putting the right diagnosis on the problem list and then managing it from there appropriately that's a real barrier. Yep. What's the right code? Oh my gosh, I just look at the GFR to make sure I know which level it is, and then I got to look at that, and I got to look over here. What's the right code? That was the last thing that seems important. Absolutely.
I think,
yeah,
Dr. Bauer here, I think also the other issue is that, we had already been, almost everyone had already been on ACE or ARBs prior to this. And it wasn't until recently that, we had the Farxiga and the Kerendia to add to this. So I think a lot of it is, okay, well, I found this is not changing what I'm doing. And now that there's more drugs and better information out, then I think, we start, it becomes more relevant.
right. Great point. Exactly. When we were all using sulfonylureas as our first line option, or whether or not we should have been. And again, we were doing the best we could with ACEs and ARBs on blood pressure management. Like you said, like what difference did it make? And now we have at least 3 or more classes of medications that have a lot of great new evidence that they make a significant difference in diabetes and kidney disease. So it sort of brings it up to the level again of, oh, okay, maybe it matters. So that's that education gap, absolutely, and sort of time gap. So Jenny, you can click through those, which we've sort of talked through, and so then I do want to move over to the managing part, and I just kind of go through, for me, frankly, some learning that I had in tackling this and sort of answering that question for my colleagues about what difference does it make. Again, we've talked through some of these things, but we just talked through the different medications, for example, for diabetes, where you're going to use SGLT2s and GLP agonists, GLP-1 agonists as your medications of preference in that order for diabetes, instead of the medications that we often used in the past, right? I'm curious around blood pressure, particularly. Do you all utilize a different blood pressure goal for folks who have CKD versus just straight diabetes? Thumbs up if you use a different blood pressure level of goal blood pressure for people who have CKD. Okay, right. We don't, but what's the evidence behind this? So we'll go through this. So again, what I've found are the challenges around managing CKD is, right, how does management change it all? We're going to talk through some of that. If you go on to the next little click through, I sort of made this complicated. The other thing is sort of unsure about how often to monitor and what blood urine to monitor, how frequent, unsure of when are you supposed to refer. Is it like when I'm getting nervous? Is it definitely, obviously, stage 5, but then you're going to try 4, but then when do you do it? And unsure about, right, what is the right management? As well as, frankly, depending on your situation, how does it work with nephrology? In certain places, if you have like e-consults and a good collaborative relationship, it can be really excellent. And still, as people progress, there can be confusion about who's supposed to be managing what, especially as you're getting more advanced in some of the laboratory evaluation and monitoring. And so figuring some of that out when that's uncertain. Sometimes, we just refer at the last second, or people are crashing into dialysis, which is definitely what we want to avoid. So these are some things that I've certainly heard amongst my colleagues as sort of the barriers to even, again, putting that problem on the problem list and doing something beyond managing diabetes and hypertension. If we go, there you go. So we wanted to give you all a little bit better sense, again, of just an outline. And again, you probably are developing these or have these in your protocols. If you've developed protocols, is really thinking, again, what difference does it make if you're talking clinicians and they're like, I don't really care, I'm doing everything I can. Again, we all sort of are aware of the change in prescription med dosing that is at variable places depending on the medication. Could be CKD3A, well, there's a lot in CKD3B that we deal with. A lot of us have been dealing with Paxlovid prescriptions, which at least primed us for thinking about this and evaluating where are they and what prescribing level do I need to be at. But thinking about how we approach medications overall and things like NSAIDs, especially early in kidney disease, again, is something could be absolutely important to folks' overall education and management. I've been surprised as I've worked in different clinics, how many folks, again, are taking NSAIDs and they have CKD3A, and I'm filling in for somebody, and this is the first time we're having a conversation about the fact that they have kidney disease, and really, that shouldn't be prescribed to them, first of all. And second of all, yeah, they should avoid other things. Having those conversations early is how, we avoid their progression. If we're waiting until they have CKD3B, and we have to change their prescription doses, then again, like the horse is already out of the barn. It's like not treating somebody for prediabetes or doing things about their prediabetes and waiting till their A1C is 9 and then deciding we're going to start doing things differently. That we wouldn't do that, right? If you move on to the next thing, evidence-based protocols do really support a more aggressive blood pressure control goal with ACEs and ARBs, right? You're using those, than you would for a person with just straight up diabetes. So evidence shows that lower goal of below 130/80, which a lot of us go, wait, that's getting a little uncomfortable. But the evidence shows, again, and you're like, wait, somebody CKD3B who's all fragile and maybe they're going to go hypovolemic and I'm worried about that. Yeah, you do worry about those things. And the studies, and I'm happy to share these if you'd like, do support pushing that blood pressure goal lower to prevent the, again, mostly cardiovascular issues. And if you're managing folks well, they don't tend to have those issues of hypotension. And so that to me was new. In learning about this, I've been using the 140/90 generally goal with the permissiveness above, people are older and all of that. That's important. The individual circumstances are important, but talking about that goal, are you comfortable with that? Do you feel like you need more evidence around that goal? And is that something you can adopt as an organizational priority in this management? If we go on to the next bullet. So again, we've talked through this a little bit, but again, SGLT2 inhibitors, those are absolutely sort of the beyond metformin would be the next line in somebody with CKD. So again, like that's a different management strategy than you have in somebody without CKD. That means even if they have CKD stage 2, you're still going to prioritize SGLT2 inhibitors, right? And then the second line below that is the GLP-1 agonists. And then also stepping up the frequency of monitoring for CKD progression. Again, not knowing when to monitor, or we monitor once a year, or we monitor twice a year, or we monitor every 3 months. How do you decide? And is it based on evidence and recommendations? Dr. Bauer, you have a question?
Not a question, just a sort of a statement. I think one thing that we all should realize is on June 23rd, when you're talking GLP-1s, Victoza goes generic. So
Mhm.
the cost of that will drop precipitously.
Yes, yes, good point. Good point. Definitely overall for diabetes medications, right? In particular, cost such an issue. And again, a lot of these new medications, we're talking about new medications with new evidence. Most of those are brands still, with that one upcoming exception. So definitely important to talk through with folks. And
Farxiga's already generic too.
yes, right. So looking for those. I'm in a situation where I have a 340B program and I'm using GoodRx a lot. And that's the situation that a lot of us are certainly in with these meds. So, and then we heard from folks as well about the desire to focus on nutrition. So that is something, again, we all think about with diabetes, but we do not typically in our routine practice consider that as a necessary step or an important step when we diagnose somebody with CKD. So that's a really critical piece that we can intervene early. So if we diagnose them with CKD 2 or 3A, we can intervene early, get them that medical nutrition. Again, it's a Medicare covered benefit. That's important to know, just like diabetes is that's Medicare fee for service and usually MA programs. So utilizing that as much as you can is certainly an underutilized or lever that we have. If we do make the diagnosis, that can make a difference. And then we'll move on to the next slide. And so we wanted to share with you all some tools that we have developed, as well as evidence-based algorithms by National Kidney Foundation that hopefully will help make it more simple for your clinicians to do this diagnosis and management work. And so we would love for you all to take a look at these resources and decide if you're going to use them and how you're going to use them, and give us feedback on them. But this heat map essentially is based on, again, off the National Kidney Foundation work. It shows you your GFR with all the numbers right there, your albuminuria, and you can diagnose somebody with the ICD-10 codes there, N18.32 for CKD3B, for example. In parentheses, it gives you the frequency of monitoring per year. So if it says 3 times per year, you're doing it every 4 months, right? If it's 4+ times per year, you're doing it every 3 months or more often. CKD 3A is the only 3A with albuminuria, or 3B with very little albuminuria are the only ones that's twice a year, right? So just looking at the albuminuria in 2. There you go. So there's a whole row of orange that's twice a year, right? All of this is color coded for you to, again, be able to look at it and go, okay, what's the result? What am I looking for? What's the code? How often am I supposed to monitor? And then if you're in those areas that are very high risk where it says refer, we gave you the specifications again from National Kidney Foundation about albuminuria and GFR, about why you would refer. And then there's a link, or if you print this out and stick it near your work desk or whatever, you can use your phone and scan that QR code and get the whole NKF management flow chart that tells you sort of from start to finish a lot other reasons why you would refer, other monitoring, things like managing anemia. There's a whole variety of things in that NKF flow sheet. We didn't want to take up space on this heat map with all that information, but we wanted to give you access to it, or your clinicians access to it. So this is an example of, again, a tool we've sort of modified based on other resources that we would love to hear your feedback on and figure out if there is uptake amongst your clinicians and teams in utilizing it, as well as what else we can do to help.
Yeah, and I have to do a quick shout out, Dr. Salino, to the St. Mary's Clearwater group for helping us get these codes. And then you may have all seen CKD heat maps before. National Kidney Foundation, KDIGO, and CQA, they all use them. This is our version of it, where we tried to put everything a provider may want to know as they're looking at a lab result. to get them started. And again, if you print it out and put it next to a desk, you can scan this to go to a treatment algorithm. If you're looking at it on your computer, you can click it. And the treatment algorithm that it links to is actually just got updated by the National Kidney Foundation. We are not paid to work with them. We have no connection with them. We do have other treatment algorithms, one through Intermountain Hospital, and then KDIGO just came out with one. They're the International Kidney Foundation. They're pages and pages long. And the reason why we've gravitated towards this one is we've received feedback from other providers that it's the most thorough but succinct treatment algorithm. It's 2 pages. The flow sheet is the first page and contains all, the newest updated guidelines. And then the second page goes into a little bit more detail. So the goal is that this heat map could be the quick source. And then if a provider was like, okay, I need some more information, they could quickly link to that National Kidney Foundation flow chart. And we will drop into chat right now the link to this heat map. It is on our Comagine website. You can print it off, you can share it, you can reproduce it. It's to be used, and we would also love feedback on it, like Dr. Salino said. If there's something you feel like is confusing or something you would want added in addition as a provider, please let us know. We can adjust it.
I think personally, I think this looks fantastic. I'm excited to get it printed off and distributed because I think it's much more comprehensive than what we were using. And I love that the codes are on there. And then the frequency of being seen, just being right there in front of you, is really helpful.
I'm printing it right now. So
Yeah.
go put it in the care areas. Yeah, no, this is helpful. And I like having the QR code in there. That's great. This is really well done. And yeah, we haven't really rolled out this part of it. The way that we have been implementing it, Clearwater St. Mary's, is sort of staged, like wading people into the water, and we were getting just launched on the testing. And our intent was in March to then link to treatment plan. So this is perfect timing, and this is a great resource. Yeah, cool.
And I will say one thing, and I don't want to steal Dr. Salino's thunder. I apologize if you were going to say this, Dr. Salino, but we have been working with clinics in our 6-state region, both on blood pressure, CKD, and diabetes. And we are always encouraging clinics and providers to adopt an evidence-based algorithm. And I know from my clinical experience, there's probably nothing less that a provider wants to do than be told how to treat something. And we know there's always exceptions. But what we have found from different groups who have adopted it, including the LA County clinics who adopted an SMBP program, is that by doing an evidence-based algorithm, you can create standing orders more easily. And also it allows everyone on the care team to work to the top of their license. For example, nurses, if all the providers are going off the same evidence-based algorithm, can quickly make decisions over triage or when a patient walks in based on the algorithm. It frees up providers from having to answer so many one-off questions when an RN is able to work off of an algorithm. So of course, we know there's always exceptions and always extenuating circumstances with patients, and of course would want providers to take those into account. But generally, that's why we like algorithms like this, is that if it is widely adopted and implemented in the clinic, it creates efficiencies. There's evidence that shows it does lead to better patient outcomes. It allows providers to be able to do different things than just answer questions from nursing staff, because the nursing staff is able to work more to the top of their license. So I just wanted to throw that in there as a way to sort of push for adopting these on a clinic-wide basis. Again, doesn't have to be this one. If you're interested, we can also send out the links to the Intermountain and KDIGO ones as well. They're much more extensive, but have a lot of good stuff in there. Questions, comments, discussion about this? Okay. Well, Dr. Salino, thank you so much. What we are going to do now is we're going to take a 5-minute break, and then we're going to go into our clinic breakout sessions. And we're going to have a good 40-ish minutes to work on our next test of change, next PDSA cycle. So the goal is to hop in a breakout room with your practice facilitator. So when you get back from this 5-minute break, that's what we'll be doing. And then we'll do a quick share out and wrap up. Dr. Salino and Ann Jensen, our data analysis, are going to stay on the call kind of in the waiting room. So as you're planning as a group, talking through, if you have questions about data, about planning maybe a test of change around CKD management, both Dr. Salino and Ann will be available. So we'll see you guys back in 5 minutes. So that's what, 2:12, and we'll go from there into breakout rooms. See you guys in a couple minutes. Okay, well, welcome back, everyone. We're just going to do a quick share out if people want to share what they talked about. I'm going to throw the St. Mary's Clearwater people out there first, since I was in that group and I know they have something to share.
I think, well, basically our next PSA is going to be to share the heat map that you guys provided today. And then our test of change is going to be to distribute that. And then we're going to monitor, hopefully to increase by 28 patients, diagnosing them with CKD or capturing the correct diagnosis and using the, I forget what the codes are off the top of my head, but excluding the diabetes with nephropathy, because we still have a few patients with those diagnoses, and then CKD unspecified.
Yeah, so it's the N18.1 through N18.5.
Yeah.
We're struggling with like, how can we capture in the data that providers are analyzing their lab results and making, like diagnoses that hopefully then are linking to like the treatment pathway. And the measure 1 that we're tracking, the number of patients diagnosed with CKD, Alyssa's tracking that manually each month. And so she can see which patients are still being diagnosed with CKD unspecified or the CKD nephropathy, which is what we're trying to move away from to something more specific. So that's why we chose kind of that is like a proxy measure for if providers are going to be incorporating the heat map and the algorithm into their charting and workflows. Nikki, I know you shared that you feel like as a provider, this has really changed the way you've been practicing, which I mean, there's nothing better in the whole world for us to hear than that. I don't know if you had anything you wanted to share about you saying you reference your heat map pretty often.
Yeah, so as a new provider, I'm fairly new. I've only been practicing as a nurse practitioner for about a year now. So a lot of this stuff was very new to me. You don't learn all of this stuff in school. And so the initial heat map that, we pulled when we first started this project is I kind of put it in my Word document that I have for chronic kidney disease that I reference. And I honestly can say I probably reference my Word document for that at least once a day, if not more than that. So it's really helped me to obviously change the way I practice and or give me a pathway to practice, not necessarily change it, because I don't know that I had a real plan when I was, just because I'm so new and starting out, but it's really helped me for sure a lot.
Yeah, Michelle, go ahead.
I had a question for Alyssa, or an observation, or maybe just expand on it a little bit more. You said something that kind of triggered in my head. So when you're trying to pull your testing to see if you're improving, you said taking diabetic nephropathy out of the equation. A lot of our codes are diabetic nephropathy because a lot of the insurances and the HEDIS measures and the HCC coding wants you to do diabetes with something. Don't do diabetes unspecified. So how are you managing that?
Dr. Salino, I see you're still on the call. Do you want to hop in here and do your quick explanation there?
Yeah, you could totally recognize that, and sort of, again, that's the pattern that we have historically followed. In terms of the diabetes with, I'll say that if people have nephropathy, usually they have something else as well, like hyperglycemia, is just one example, right? They're going to have that before they have nephropathy. They're going to have with hypertension is another good with, usually before they develop chronic kidney disease. So there are they can choose anything that they are managing in terms of that diabetes and say diabetes with whatever. I'll also share that again, I'm not a coder, but in the new model for HCC coding, it does not matter. The value does not change if you say a patient has diabetes without complications or diabetes with complications. That was not the case in the old model. The old model, it mattered a lot if they were with complications or without complications. So point being is I tell people to manage with their diabetes whatever they're managing that is out of control. Sometimes it's nephropathy, but most of the time it's a lot of other things like hyperglycemia every time. And what I want people to recognize is by just keeping the nephropathy there, which is obviously a different organ system, it gets lost. You forget all of the differences that the stage of CKD where it changes your management and monitoring. Hopefully that makes some sense. I see Dr. Bauer, you have your hand up as well.
Well, since you're talking, I've been asked to ask you a question. I'm going to ask you some more. First of all, they were talking about nutritionists, and I was saying, well, if I apply the rule of going to a nutritionist, has it ever been shown to change all-cause mortality? I'm not aware of any study that shows that going to a nutritionist for this changes all-cause mortality. Am I wrong?
Great question. I don't know if the visit with the nutritionist has been studied. I'm going to look at that after we get off this call. I don't know of that specifically. What I can say is certainly the dietary changes that are like a DASH diet, et cetera, around hypertension do have evidence behind them in terms of slowing progression. So
I know like a Mediterranean diet is, and then those have even been, there's been where if you do it prospectively, that hasn't been shown to be as beneficial. And then I guess the next question, we were talking about getting blood pressure down, and my office manager astutely said, yeah, Dr. Bauer, you've sort of been letting it go up into the 130s and 140s recently. I go, yeah, because I've had a lot of people come back with orthostatic symptoms have fallen. Yeah. And the rule in medicine is first do no harm. So yeah, maybe algorithmically, if you take large populations, the benefits outweigh the risks, but that's not the oath. The oath isn't benefits outweigh risks. It's first do no harm. If you have a few people falling, that's on you. And as I said, there's really only 3 or 4 safe blood pressure medicines that have been shown to improve all-cause mortality, and that's diuretics, chlorthalidone, ACE and ARBs, amlodipine, and beta blockers. Anything beyond that really isn't showing a mortality benefit. So I guess I'm wondering, what are we doing with those with hydralazine and clonidine besides causing other problems?
Oh yeah, totally. This is a really good question, and I'll address it a few different ways. First of all, the medicines without evidence behind them, again, like we should, except in very rare cases where it's an individual situation that necessitates something like hydralazine, we shouldn't be using those, right? We should be using other medications. There is a new non-steroidal mineralocorticoid sort of a medication that has some evidence around kidney disease that I'm blanking on the name of it right now.
Corandia? Is that Corandia, or which one is that?
No, it's a different name, but your point is correct that when we're looking at protocols that are evidence-based, right, they're basing those on population studies. And I'm happy to share again, because I asked the same question, what is the basis for knocking that goal down to 130 over 80 instead of 140 over 90? And in developing protocols, folks do go through and share the evidence around why that is. And these are protocols to use as a goal, and everything is individual. So absolutely, as you have folks that are older and more frail, you are worried about that hypotension. If people have hypotension, again, we should absolutely pay attention to that. We should think about, are we getting accurate blood pressures? Are we taking it appropriately? Do we check home blood pressures instead of always in the office? Those sorts of things that drive it. And again, the evidence supports still that 130/90, less than that being the goal. You may or may not be able to reach that goal based on that individual, but I'm happy to again share the evidence behind that number and recognize that absolutely correct. Everything's individual, and you have to pay attention to the patient.
Yeah, I accept the evidence. I was really hard on it, except that then I had a few bad things. I'm like, well, all right, been there, done that. I don't want to cause harm first, and so I guess that's sort of the fly in the ointment for me.
Totally, and again, that's the trick of having guidelines, but that you may agree are evidence based, and evaluating those based on your patient population and the individual patients, and do things fit with that person. And when they don't, you don't want to. You have to modify your strategy. Absolutely.
Well, thank you. And I'm going to interrupt and say I've been tasked with managing the last 5 minutes of this event. So I want to give Michelle, first of all, Michelle, did you want to share your PDSA or your plan really quickly?
Oh, sure. It's nothing major. We're a little behind on getting this rolling. So we are really just going to actually put into effect our plan to increase our UACRs with the EGFR, obviously by increasing the urines, and just get on board. You guys all gave us some obvious thoughts that my aha moments that we just hadn't put into words. So create the algorithm standing order that says, patients based off diagnoses, CKD, hypertension, diabetes. You are going to do the kidney profile, which is going to be put into the EMR. Increase our verbiage to our patients with, your next lab draw is going to include a urine, the reminder calls, which I love and hadn't thought of, to make sure that they state something to that effect generically, because we can't separate those reminder calls out, but have our front desk, if somebody says they need to use the bathroom, offer them to leave a urine just in case we need it. Not every patient, just if somebody says they need to use the bathroom first. And basically just try to aim for improving by like 10% by our next breakout here, so that we can see what we're doing and how we're improving on it. And then we'll move on from there.
Thanks, Michelle. Thanks for sharing that with the group. Does anybody have a question for Michelle? No? Okay, so we'll move on to the next slide here. I'm going to ask you to share your thoughts about today's collaborative meeting. What was the most useful for CKD quality improvement today? And what can we change during the collaborative sessions to be the most useful for you? And instead of having a discussion today about this, I would really like you to just type it into the chat if you can. If you have more than one thought, just keep on going. Just type it in there. We have found that asking you to do a survey after the event is very difficult to get people to participate. So we just really want to have your comments in the chat if you don't mind doing that. But Jenny, next slide. So while you're doing that, I'm going to talk about the action period 2, which is action periods are what you're doing between learning sessions. You're going to begin your improvement process using PDSA, stay connected to your practice facilitators, and try to make your monthly calls with your practice facilitators that are useful for you, and submit your monthly provider level data. Next slide. And then, and this is the list of practice facilitators here. And I think you guys all know who we are and how to find us. And our next session will be on Thursday, May 16th. It'll be noon to 2 Pacific time or 1 to 3 Mountain Standard Time. And we're going to focus on reviewing our data, our PDSAs, where we're at, and we'll have a nephrologist, Dr. Loger, MD, will share evidence-based parameters for appropriate collaboration with nephrology and co-management of CKD. So looking forward to that. And I think our last slide will be continuous improvement is better than delayed perfection. This photo was taken with an iPhone in an airplane over the mountain. I think you can guess which mountain this is, but you know, you guys are doing great work, and we appreciate your participation. I've heard a lot of good things today, and I just want to thank you.
Looked like Dr. Bauer had a question.
Oh,
Yeah.
sorry.
Yeah, I was just gonna say, you mean Mountain Daylight Time, right?
Yes.
Okay.
Mountain Daylight Time. Perfect. Perfect way to everybody just enjoy the rest of your day today. Thank you.
Bye, everyone. See you soon.